Neha Pagidipati and Dr. John Stanifer.
That's good.
Thank you.
Job,
so Dr. Neha finished her final year of at Duke. She completed her undergraduate medical school and public health training at Harvard before internal medicine residency at Brigham, and also completed a 2-year research fellowship in global women's health at Brigham before writing here at Duke. Her primary clinical and research interest is in prevention of cardiovascular disease, particularly among patients with metabolic disease, and in that vein, she'll continue her research as a Duke faculty member next year and will help to launch the new Duke Cardiometabolic Prevention Program, and will continue her research at the DCRI, which primarily focuses on lipids, obesity, and diabetes management in high-risk individuals. We'll also be hearing from Dr. John Stanifer, who attended medical school at the University of Tennessee, completed his training in internal medicine and global health here at Duke, and as part of this training received a Master of Science in Global Health and spent a year in Tanzania conducting the CKD Africa study, after which he returned to begin his nephrology fellowship at Duke. And after he completed his first clinical year, he transitioned to the DCRI fellowship program in 2015. And next year we'll be joining the Duke Department of Medicine and Global Health as faculty, and plans to continue his career as a physician and academic researcher. So we are so excited to welcome our fellows today, so please join me in welcoming them.
Thanks, yeah. Well, so first, thank you guys all so much for coming. This is awesome that you all made the time to come chat with us today. I think the first thing that we both wanted to do, though, is just to say how privileged we were to be the Chief Fellows this year. I think it was a really amazing experience, and I think looking back on it, there are not very many places where 30 individuals in the midst of their training with completely different backgrounds and completely different research interests can come together, form a cohesive group, and every one of us can find the support that we need to do our research and succeed. That is a really amazing thing, and there are probably no other places in the world that can do that. And so I think we feel both really privileged to be a part of this.
Yeah, I pretty much can't say.
Okay, well then there we go. All right, there we go. Okay, that was our intro, emotional intro. Okay, so thanks for having me. I don't have any relevant interest disclosures, but they're up there on the website anyway. So, am I not mic'd? Hair. There we go. All right. So, So why cardiometabolic health? And I think the term cardiometabolic, which not only because I'm pushing it, but because I think a lot of people are pushing it, is being kind of increasingly used and increasingly recognized because we're learning that the same things that promote metabolic disease, obesity, diabetes, are the same things that promote cardiovascular disease. And they're the same patients that get both. And so we're really starting to recognize that individuals who care for people with cardiovascular disease also need to know how to care for their diabetes and their obesity. And the reason that I kind of came into this is because I started my journey in medicine actually in India. So I went to college up in Boston, and the year after I graduated from college, I went to India. I got a grant to do maternal health care access work. And I got to India all kind of fresh-faced, and I was in Chennai, and I was expecting to see women who looked like this, right? And instead what I saw was women who looked like this, and I was shocked. And at the same time was when, this was a long time ago now, when I was in college, this was like 20 years ago, and this was when kind of the epidemic of cardiovascular disease in India was just starting to be recognized. And I was noticing these changes at the same time that the cardiovascular disease epidemic was rising, and obviously this can't be a coincidence. So this is really where I started my kind of journey in cardiometabolic disease. And over the next about 20 minutes or so, I'd like to just talk to you a little bit about highlighting some of the cardiovascular risk in metabolic disease, some of the newer advances that have been made, because this is a really exciting time in diabetes and cardiovascular care. Talk about some of the things that we've done to highlight some of the problems in managing these patients, but then we don't want to focus just on the bad stuff. We want to figure out how to make it better. So I'll spend the last couple of minutes talking to you about some of the things that a group of us is working on in the implementation space. So you've seen these maps before, and it's basically on the left side of each of them. The left side is obesity, the right side is diabetes prevalence. And in the US, over the last 20 years, things have just gotten redder and redder and redder, which means we've gotten fatter and fatter and fatter. And now obesity in men, it has about a 35% prevalence. In women, it's 40%. And 12 to 14% of Americans have diabetes. So obviously, this is a growing problem. And we know that people with obesity have a higher risk of cardiovascular disease. So this is a meta-analysis from it includes about 300,000 patients. And what we see down here in the red box is that people with obesity compared to people who are normal weight have a 49% higher chance of getting coronary heart disease. And that's after you account for the fact that they have other stuff that goes along with their obesity that contributes to their coronary heart disease, like blood pressure and lipids. The blood pressure and hyperlipidemia only accounts for about 45% of their risk. They still have a 49% increased risk left over. So we know obesity is bad for cardiovascular disease. And the same is true for diabetes. And this was a meta-analysis of 102 prospective studies, and they found that individuals with diabetes have a twofold increased risk for coronary heart disease, and the risk for ischemic stroke is even higher. So we know that diabetes and obesity are bad. What are we doing about it? So I'm just going to outline some of the newer advances that have been made recently. And this, just to kind of highlight some of the things that are being done in obesity. So on the left are some of the older therapies, and on the right...
Sorry, how controversial is the direct relationship between...
I love that you just stopped me in the middle of my sentence. You're so cool.
Because I have the impression that most of the relationship between weight and cardiovascular disease was really driven by things that come along with being overweight.
Right.
That just being overweight is not in and of itself bad.
Yeah.
And this I remember from maybe 5 years or so. I don't know if that thought process has evolved.
Yeah, so I actually took out a slide, and I wish I hadn't now, because I didn't realize you'd be here asking me this. So there is actually, so yes, it has been very controversial. Like, what is it? How causal is obesity for cardiovascular disease, or is it all the other stuff, like the blood pressure and the hyperlipidemia that goes along with it? So it's this really cool. Last year, I think it came out in Lancet, there was this Mendelian randomization study that looked at individuals who are genetically predisposed to have a high waist-to-hip ratio. So as you know, abdominal obesity is worse than general obesity. So they were looking specifically at abdominal obesity, but they found that people who have a genetic predisposition for a high waist-to-hip ratio also are much more likely to have cardiovascular disease. And when in the context of these Mendelian randomization studies, this kind of gets at the issue of causality. So that at least gives us some suggestion. But you're right, it is really hard to tease that apart. That being said, I think that there is something causal there, but it is hard to tease that apart. So thank you for bringing that up and not letting me get away with it. So for obesity therapy, so some of the older ones are on the left and some of the newer ones are on the right. And basically, we do not have good medications. We know how to make people lose weight, we think, but through medications, it's not that easy. Through surgery, it is actually quite successful. A couple of the medications that you see up here, Anne-Marie laughed at me with this. Orlistat, called Fatless, is one of them. It's a horrible medicine. It gives you like all sorts of GI issues that you don't want. Belvic is lorcaserin, also has a lot of side effects. Most people don't take any of these medications. Metformin is not an obesity medication per se. It's really a diabetes, maybe a pre-diabetes medication, but it actually leads to people losing weight as well and has some cardiovascular benefit. And then these are examples of the surgical procedures that are performed, and surgery is extremely successful, not only in making people lose weight in the long term, but in curing diabetes, not just diminishing it, curing it, and also in improving cardiovascular and all-cause mortality out to 10 and 20 years. So these are incredibly successful procedures that are really underused all around the nation. And some of the ones that you see here, this first one, I think my pointer doesn't work. There it is, a little bit. This is the classic Roux-en-Y gastric bypass. This is a sleeve gastrectomy. Basically, you've just sliced off part of the stomach. And then this is the adjustable gastric lap band. These are all things that we actually have available here at Duke. Some of the newer medications that I've highlighted up here are the GLP-1 agonists. Byetta is a daily formulation of exenatide, and Saxenda is a high dosage formulation of a liraglutide. Those both these are actually diabetes medications. They're A1C controllers, but they lead to significant weight loss, especially Saxenda. And then this is just kind of fun. None of these are available here, and you'll see why very shortly. This is an intragastric balloon that is put in, again, this is all like investigational, intragastric balloon that is put in endoscopically, and it blows up and it makes you feel full, but If you leave it in for too long, it pops, so don't leave it in for too long. Then this one is actually a good one. This is actually the mini gastric bypass, and this probably has a lot of potential, and I don't know if we do it here or not yet, but we probably will start doing this. This is basically a version of the gastric bypass, but it has only one anastomosis instead of two. It's much easier, it's much quicker, and they're testing the longevity of the procedure right now, but preliminary data looks good, so that's probably a good one. This is called the endobarrier. You basically put this plastic endoscopically inside your jejunum, inside your small intestine, so that you can't absorb anything. People don't like that. And then there's this one, Aspire Assist. Aspire Assist is basically you put a tube inside your stomach, and every time you eat, you let it out. Yeah, exactly. So anyway, these aren't popular, but I'm just saying that these are out there. Okay, so now let's talk about the diabetes ones, which are more exciting in the cardiovascular space. So as many of you know, for decades, we have not been able to move the needle on cardiovascular disease when we treat diabetes, right? So just by lowering A1C in people who have diabetes, we have not been able to improve their cardiovascular outcomes until very recently. And as you know, in 2008, the FDA mandated that all diabetes medications that needed to go on market would have to first prove that they were safe from a cardiovascular perspective. And this really happened in the wake of the sulfonylureas, which had an increased risk of MI and death, and the TZDs, which had an increased risk of heart failure. And lo and behold, they found that several drugs not only are safe from a cardiovascular perspective, but actually improve cardiovascular outcomes. So I'll just quickly go through a couple of them here. The first one is, the trial was called EMPA-REG Outcome, and this came out a couple of years ago, I think in 2013 or 2015, I think. And that's empagliflozin. Empagliflozin is an SGLT2 inhibitor. It basically gives you sweet pea. You pee out the glucose. And they tested this drug in patients with secondary prevention patients, so patients who had diabetes and known cardiovascular disease. They followed people over about 3 years, and what they found was a 14% reduction in the primary outcome of MACE, 38% reduction in cardiovascular death. I mean, these are huge numbers in the diabetes space. And in heart failure, very surprisingly, 35% risk reduction. And it's unclear exactly why that is, and maybe I'm sure Rob knows more about this than I do, but the curves split very early on, and so the thought is that there may be some kind of hemodynamic effect because it actually acts as a diuretic. You're peeing out sweet pea, but you're actually getting rid of some of your volume, and maybe that hemodynamic effect is what's leading to some of the benefit that we see in heart failure. Then,
Kidney benefit.
Yes.
and a kidney benefit too.
largely kidney, actually.
Okay, and then actually one that just came out like yesterday or day before Canvas. Yesterday, right? So I don't know all the details about Canvas, but Canvas is another SGLT2 that was tested, canagliflozin, and that also had a significant benefit in the overall, it was overall MACE, significant benefit, not a benefit in all-cause mortality, significant benefit in heart failure hospitalizations. Again, the curves split very early on, but it makes you lose your toes. They were, but not your leg, so they said it's not that bad, it's just your toes, like a twofold increase in losing your toes. So so for leader in SUSTAIN 6, these were testing GLP-1 agonists, and in liraglutide, it tested both a primary and a secondary prevention population, and again, a 13% reduction in MACE, 22% reduction in cardiovascular death, no effect on heart failure. But in semaglutide, this was a much smaller study, you see a benefit in MACE, and actually a benefit in stroke. So it's kind of interesting, you have these kind of differing outcomes with two drugs from the same class, and it's leading people to wonder whether there's a class effect or a drug effect, which brings us to Excel, which as many of you know, we just database locked several weeks ago. Rob was the clinical lead on that, Adrian was our PI. And this is from the press release, which basically showed that it was non-inferior to usual care. This is once weekly exenatide, so it's, again, another GLP-1 agonist like liraglutide. Non-inferior, but not superior. And then the full results will be presented at EASD in September. So I'll just quickly go through some of the things that we've done to talk about what some of the problems are, and then hopefully talk about how we can start to fix some of them. This was a study that we did in NHANES. So as some of you know, a big issue is who should be treated with statin therapy for primary prevention. And in 2013, the ACC-AHA came out with guidelines that were a real paradigm shift. It shifted physicians from thinking about LDL levels to thinking about the risk of the patient that's sitting in front of them. And one part of the guidelines said that for individuals with diabetes, it doesn't matter, all individuals with diabetes would get treated, it's just depending on their level of risk, it decides whether they would get treated with a moderate or a high dose statin therapy. But again, the idea was that people with diabetes should get treated with statin therapy for primary prevention. Then came along the United States Prevention Services Task Force guidelines in 2016, and they kind of made it a little harder across the board to get primary prevention statin therapy. What they said was, as opposed to the 2013 guidelines where you had to have a 7.5% risk to kind of qualify or be eligible for statin therapy, they made it a 10% risk, but only in people who have at least one cardiovascular risk factor. So you have to have either hypertension, dyslipidemia, smoking, or diabetes. And what this means is that individuals with diabetes who don't meet that 10% risk aren't necessarily recommended to receive statin therapy. And so we wanted to see what does that mean on a population level. And we looked at NHANES data between 2009 and 2014 in a primary prevention population and looked specifically at who would not be treated under the newer guidelines. And it turns out that about 9.3 million Americans would no longer be eligible for statin therapy under the USPSTF guidelines compared with the ACC-AHA guidelines. But who are those individuals? And if you look here, this is splitting up the folks who would be eligible for statin therapy both by age and by diabetes status. And if you look here on the top two rows, you can see that there's about 2.5 million fewer diabetics, these are the diabetics in the orange, who would be treated under the USPSTF guidelines. And as you see, in the older folks, there's not that much of a difference. It's the younger diabetics. So we're not, under the new guidelines, we would not be treating nearly as many younger diabetics. And as Eric Peterson likes to say, younger diabetics have a tendency to become older diabetics. And should we really not be treating them? So that was one of the things that we looked at. And in TICOS, which was another cardiovascular outcomes trial that was run here, testing sitagliptin against usual care, this had a large population of people with diabetes and cardiovascular disease across 38 countries. And we looked at, well, for these folks who have diabetes and known cardiovascular disease, how are they being treated? Are they getting all of the care that they should be getting? And that care includes aspirin use, having their lipids controlled, having their blood pressure controlled, being on an ACE or an ARB, and not smoking. And it turns out that we do pretty well globally, but blood pressure leaves much to be desired. And if you look at the folks who have all 5 of those things, which should be standard of care, less than a third of patients actually had all 5 of those things under control. And this is in a trial population, which if anything, you would think would be receiving better care than the average population. And each of these dots represents a country, and on the bottom, it's the columns are which of the parameters for secondary prevention they are. And what you can see is really that they're much more than variation between the parameters. There's variation between countries. So there is a lot of variation in how patients are getting treated globally that varies by country. And so we're getting there, but we're not where we need to be yet. We looked at folks in TICOS and in terms of their obesity. And over 80% of the population in TICOS was overweight or obese. Half of them were obese. So a lot of people were overweight. And we looked at how they did over time. Again, the purpose of TICOS was not to make people lose weight, but they were being watched very carefully in the context of a clinical trial. And what you can see from this is that the light blue bars basically don't change all that much, which means the weight of the vast majority of people did not change. Yes, the very obese people did lose a little bit of weight, and the underweight people gained a little bit of weight, but overall, people didn't really change. So do we do any better here at Duke? And if you, I don't know, those of you who are taking care of patients at Duke, you know that we have a hefty, that's the wrong word, we have a sizable population of overweight, so I didn't mean to do that, overweight or obese people. And so 73% of our population is overweight or obese. 40% of our population is obese, okay? And how are we doing in terms of medications? So the medications are by no means perfect, but you would expect that at least some people should be on them. In a population of, this includes 170,000 Duke primary care patients, okay, who were followed between 2013 and 2015, and with follow-up to 2016. You can see that basically no one is on these medications, and I didn't include some of the other ones as well, which are even less likely to be used. No one's on those either. The only medication that's getting used is metformin, and that's because these people are diabetic, not for their weight loss particularly. And then if you wonder, do they lose weight? Do our patients lose weight? The answer is no. You can see that basically everybody, across, no matter where you start out in your BMI, weight doesn't change over 2 to 3 years here at Duke. So we're not doing as good of a job as we could be doing as well. So instead of complain about it, let's make it better. And I'm going to skip through a bunch of these things because I don't want to take up John's time. Just to say that some of the things that we're working on, so my K23 that it does not yet exist but will one day exist and will one day be submitted is on pre-diabetes, because 1 in 3 individuals in the US are pre-diabetic, and we know that they have a 20% increased risk of cardiovascular disease compared to people who are not pre-diabetic and who have normal glycemia. But the question is, there are so many of these people with prediabetes, and we know how to treat them. It should be intensive risk factor modification. That's really expensive and really hard to do in a large population. So we're going to try and figure out who is the highest risk among people with prediabetes, try and figure out whether those people with prediabetes who go on to develop cardiovascular disease actually had to develop diabetes first. So is it all, like Ben was saying, is it all the other stuff that they have being pre-diabetic that leads them to cardiovascular disease, or is it that they go on to develop diabetes? And then we're going to test this kind of novel mobile health app. It's called GlycoLeap. It's based here, the company's based here and in Singapore. And the way that GlycoLeap works is they give people weighing scales, glucose testing kits, less applicable for the prediabetes population, but each individual has their own kind of personalized nutrition coach, and they're a registered dietitian, and you take pictures of your food, and they give you feedback within an hour of all of your meals. And the company's initial data is very good, that there's a lot of adherence and people are losing weight and getting their A1C under control. These things have to be tested rigorously, and so that's part of what we're going to do. I'm going to skip over some of this. This I can't skip over, Anne-Marie. This is Barnhill. So this is a project that Anne-Marie is leading, and there she is at the site at one of the screenings. So Barnhill Contracting, you may have seen their flags and their signs. They're a really large contracting company in North Carolina. They have 1,200 employees, and the CEO of the company is really interested in prevention. And what he's been doing is screening his employees by having them come once a year, telling them that they have cholesterol or blood pressure problems, handing them a sheet and saying, now go forth and fix it. And it's not working, and they're wondering why. And so we've actually done some really fun stuff going out into learning all about grading and asphalting and stuff like that, and talking to folks and figuring out what the issues are. And 3 of the big issues are really physical activity. These folks think that they're very physically active by being out there and working, but it turns out that the physical activity that we think of to prevent or control diabetes and heart disease is not the same as what they're doing. Lunch choices are incredibly difficult for people, and there's a lot of canned food that gets consumed, and then a lot of these individuals smoke. So these are some of the things that we're going to work on doing an intervention working with our behavioral economist colleagues in the Dan Ariely lab. And last but not least, I want to just talk about the cardiometabolic prevention program that we're starting here. So it will have 3 components: cardiac rehab, community outreach, and the cardiometabolic clinic. And the cardiometabolic clinic is going to consist of a high-risk lipid clinic and the cardiometabolic part, where we're going to co-locate cardiology with endocrine and with renal to try and really manage these patients kind of at the point of care with all the specialists that they need to have managing their care. And this is hopefully going to be what we consider kind of like a state-of-the-art clinic of the future, where we're collecting data on these individuals, we're doing rapidly iterative trials to see what works, what doesn't, and collecting information to see whether or not what we're doing is actually working in the long term. So I just wanted to thank everybody really fast. I just made it in time. Eric, of course, my primary mentor, who couldn't have gotten through this place without him. Michael, thank you, Michael, for coming. And Anne-Marie, of course, and Rob Mentz, Ben, Matt, Hillary, Pam Douglas, who's been a great mentor to me as well, and then all of these folks who are working with me on the prevention program. So that's it. Thank you guys very much. I don't know if we should do like 2 minutes of questions if anybody has any, and then do John, or go straight to John.
Questions for you, and then
Okay. Okay. Yes.
What would be wrong, you mentioned early on that surgery works well.
Yeah.
And then you didn't mention it ever again.
Yeah.
What would be wrong with surgery as becoming a component of standard of care, where at some point everyone just gets, they reach a threshold and get whatever surgery is best at the time?
Yeah.
Why is that not part of the
Why are we not doing it? No, I think that's an excellent question. I don't have, go ahead. Preventively doing it before they get fat?
Yeah.
Before they get fat?
Well, I was going to comment that most of your talk wasn't on prevention; it was on treatment of metabolic disease.
You're
and I was
right.
wondering
It was on prevention
where do
cardiovascular.
diet and exercise, and
Yeah, it was on prevention
Like-
cardiovascular.
and how medicalized? I mean, it's again we run the risk of medicalizing a lot of these lifestyle issues.
Yeah.
But these are all related.
Yeah, no, I mean those are excellent questions, and I think what you're asking me is, why aren't people exercising and dieting more? Or how can we make them do that?
Well,
And it's a great question. It's something we're thinking about a lot.
So I guess I'm looking at having had family members who've gone through gastric bypass from a an individualized health perspective, it becomes you have it, and it almost kind of forces you to change your lifestyle in some way, because you could only eat so much.
Yes, absolutely.
But it's, I could see the disappeal of surgery, but you're not taking drugs for the rest of your life.
You're absolutely right. It is being
But there seems to be
woefully
and it
underused.
seems to be a stigma that this isn't just, how can this be incorporated into primary care, either as a preventative or simply saying, trying to define when is the threshold.
When is the threshold,
that we
yes.
should do, and it doesn't sound like people are thinking along those lines.
I think you're exactly right. And part of what we're hoping to do in the cardiometabolic clinic, so for example, here at Duke, I don't have the statistics, we're working on it, on exactly how many patients get referred to bariatric surgery. It's far too low. It's far too low nationally, it's far too low here at Duke. And part of what we're hoping to do is in some ways to be kind of a funnel for bariatric surgery, because in a lot of ways I think individuals aren't thinking about it. They're not only, primary care providers and so forth, they have a million things to do on any given visit. It's not that people don't care, and it's not that people don't care about obesity, it's just that there are 5,000 things and the other things might be more urgent. And so not only are people not getting referred to bariatric surgery, they're not getting kind of the many steps that they need even before bariatric surgery. If you're wondering about why do they need many steps before bariatric surgery, that in a large part is there for payment issues. I mean, insurance requires that you go through an algorithm of at least 6 months where you've tried multiple things and you have to document that you've tried all of these things to lose weight beforehand. So part of that is a kind of a reimbursement requirement. But you're exactly right that we're not referring nearly as many people as we should be. And the idea is we should be referring everybody with a BMI greater than 40, or thinking about it at least, and anyone with a BMI greater than 40 or a BMI greater than 35 with at least one cardiovascular risk factor, which they all have. So that's like the majority of our population, and yet we're not doing it. So I agree that we need to be thinking about that. Yeah, Abhinav.
That's great talk, Neha. I was actually very curious about the concept of weight loss in this population, and I think it's very under-evaluated in the sort of the high-risk obese patients. So, for example, when you look at heart failure, trials such as the Scales diabetes trials, which looked at the liraglutide as a weight loss agent, they almost excluded patients with heart failure. And then when you look at trials like FIGHT, yes, liraglutide works in terms of a weight loss agent, but then there are signals of harm that may potentially come out of it. So I think we have to be a little bit careful when looking at these weight loss agents, especially in the higher risk patient population. So once they've already developed end-stage disease, we may actually be seeing signals of harm potentially in those. So I think we need to be a little bit cautious from that point of view. So I like your approach of how do we target and prevent things from happening before you develop these adverse consequences.
That's a great point. Rob, you had a...
I was just going to say, I think the discussion around gastric bypass, it's a challenge. So I feel like 95% of my patients are morbidly obese, and it's striking. I've been able to get one of them to surgery, and just as you highlighted, it takes the 6-month period where they have to go to a clinic, and then we're not even a center of excellence at Duke, so you have to do it at Duke Regional.
Yep.
But they won't take anyone with comorbid conditions, so it's this kind of counterproductive. So I would think through, as you have this center, I'm really excited about this, and I'd love to hear your thoughts about how you're going to try to address some of the very practical and kind of the bureaucracy of the process to work on
Yeah,
the
and I think
situation.
the first thing as we're doing is just kind of meeting with that group, because they are very focused. It is like the metabolic and weight loss center, but it's really focused on surgery. And the patients basically have to go to them already having had their 6 months of whatever. And where are they getting that? Maybe they're getting it at their primary care doctor. Most of the time they're not. And so I think it has to be kind of a concerted effort where we know exactly what they're looking for ahead of time. What they're looking for has to probably be liberalized a little bit. And then we think about it from the outset when a patient comes to us. If it's a possibility that they might need bariatric surgery, we start thinking about that from the time that they come to us, not 10 years later. Wow, you're still 500 pounds. Maybe we should think of it. And it has to be from the beginning when we see them. So I think you're right. It has to be a more integrated process than it is right now. And part of the problem is that obesity care is very fragmented, incredibly fragmented. It's kind of piecemeal. But everyone's obese and nobody knows how to kind of integrate that care together. And so that's the hope, is that the center can start to do this, but we'll see if that actually happens. So thank you guys very much. Appreciate it.
Sorry. There you go. Great. Okay, well, thank you, Neha. And I think this actually is a very nice segue to this talk, believe it or not, which is about kidney disease, chronic kidney disease disparities from global health to local health. And I want to tell you a story about kind of how I've approached it, and you'll have an understanding of that, of why I do the work in Robeson County, which we're going to talk about in kidney disease disparities. But as anyone that'll tell you that have seen me talk, I can't talk without talking about global health first. And when I tell you some of the facts about diabetes and obesity in Robeson County, your head's going to explode, Neha, I think. So first I want to give you a broad picture and paint wide strokes about kidney disease globally, and then move to local disparities in kidney disease. And eventually I want to then move into some of the stuff we're finding in the Kidney NC study, which is something I've been working on the last 2 years while here at the DCRI down in Robeson County with the Lumbee Indians, and some of the findings and opportunities that I think it's leading to as I've just submitted a K award and transitioning into faculty. So my hope is that you'll see this and be excited and then want to collaborate, because this stuff is hard to figure out. Personal encounters. This is a 65-year-old female that came to me with chronic kidney disease stating, I think it's from the water, it's contaminated because of the wells. You know, when we first moved to the house before we got public water, we couldn't even cook with it. And as far as drinking it from the spigot, forget about it, it was too rusty. We would have to buy water or get it from my grandma's house. Or this lady, that 72-year-old female, I've had 4 aunts to die in the last 2 years with it. I wake up one morning and, you know, it's just like it's there. My mother had it. She had a twin sister. We buried 4 of her siblings, and she had an identical twin with it. We learned to cope, but oftentimes I don't think we know how many of us have it. And I think these really highlight what to me is a true health disparity. So what is a health disparity? Health disparity is a health difference arising from the social, environmental, and economic disadvantage. They tend to affect, or they have to affect, certain populations or subpopulations, and it also includes a structural failure on our part to address these inequalities. And we know that health disparities are complex. If you look at the socio-ecological model, individuals live within a network, live within organizations, live within a community, and live within a society. And failure at any of these levels or all of these levels lead to health disparities. And health disparities in chronic kidney disease are particularly complex. If you look at chronic kidney disease across the world, the mortality rate is growing almost at double digits for every country. Of the 500 to 600 million people in the world living with chronic kidney disease, 80 to 85% are from low and middle income countries. So very disproportionately affecting people in low resource settings. And it looks different across the world. If you look in Mexico, which has the highest rates of kidney disease, chronic kidney disease in urban settings, it's almost entirely due to diabetes. If you go a little bit south into Central America and El Salvador, the leading cause of hospital death is end-stage kidney disease due to this chronic kidney disease unknown, this so-called Mesoamerican nephropathy that we think has something to do with either the water or pesticides or something that's happening in these young men. Likewise, in Sri Lanka, 4% of the national healthcare budget spent on treating chronic kidney disease, unknown etiology, potentially related to well water or agricultural pesticides. In Peru, some of the stuff that's been done here at Duke, and I've been fortunate to work with Bill Pan's group at the Global Health Institute, up in the Peruvian Amazon, we see a lot of kidney disease around artisanal gold mining. So the mercury and gold runoff may potentially be impacting the kidney disease. And in sub-Saharan Africa, it's the fastest urbanizing region in the world, upwards of 100 million people living with chronic kidney disease. We don't understand the mechanisms which is driving that, but we know urbanization is potentially playing a role, and this is in part what led me during residency to enter into the global health pathway and start partnering and working on this study with this called the CKD Africa study, which we started. And this was to understand some of these very issues, starting with Duke's side in Tanzania. Duke has a long established relationship in the Kilimanjaro region, which sits in the northern side of Tanzania. And over about a year period during this time, we set about to answer the question of what's the epidemiology of kidney disease in this area and what could be potential causes of it. And it turns out there's a modest prevalence, pretty similar to what it is here overall, about 7 to 10%. 50% appears to be due to hypertension, diabetes, or HIV, or at least associated with. But that still leaves the question that 50% was a black box. So we don't know what the other 50% was. But the strongest signal that we ended up getting was that living in an urban setting. So there was something about the urban setting beyond the obesity, beyond the measured factors that we had, that was driving the kidney, or could potentially be driving the kidney disease. So we took a step back and wanted to look at some of the neighborhood or community context in which people live. And it turns out that kidney disease and the other NCDs, non-communicable diseases, appear to cluster in the urban settings as well. So we really need to look in depth at this and begin to understand what's happening from the rural to urban transition in this setting. Right? This is actually the Oldonyo Longai, that's my wife building a fire, kind of staged. But it's actually the cradle of mankind. The oldest human footprints are known to exist there. And then this is Moshi, where the urban setting of where we actually did the study. So what's happening in that transition? And this is something that that I've thought about and really want to try to get to the bottom of. But one of the interesting things that we have to take into understanding of this is the cultural context in which people are living and how they're transitioning from their lifestyles and behaviors. And one of these, just for an example, was the use of traditional medicines. Ubiquitous, right? And they take them for a lot of different reasons. But what I began to understand is no matter how excellent your care as a nephrology fellow or resident is for these people, they seek care from all sorts of different people, right? So this is where I'm getting to the point of we have to understand the context in which people live. We have to understand how they're living and why they're doing what they're doing before we can begin to formulate interventions and policies around this. So that's kind of a whirlwind tour of kidney disease across the globe and some of my background. But how do you get from East Africa to North Carolina? How is what we're doing over here affecting what we want to do here? So that's kind of what I want to show you, but and taking you through this story is highlighting how many of the things we're learning about the cultural context, the urbanization, all of these things, the methods and the very data that we're using in Tanzania are formulating now what we're doing here in North Carolina and our approach to health disparities, specifically kidney disease disparities here in North Carolina. We know that health disparities are pervasive in North Carolina. If you look at just a couple of non-communicable chronic diseases in terms of ethnic and racial disparities, vastly different for African American and American Indians in North Carolina. But there's also a geographic disparity in North Carolina, an urban and rural divide. The eastern part of the state, which is all rural and almost 50% of the state population lives, experiences much greater or far worse outcomes in terms of overall health. And the very worst county in North Carolina actually is Robeson County. There's 100 counties, it ranks number 100. And so what does that look like for kidney disease? Well, it looks pretty similar. Kidney disease is the 8th leading cause of death. Minorities, ethnic and racial minorities, twice as likely to die from kidney disease, twice as likely to develop end-stage, 3 times as likely to develop end-stage renal disease. And a stunning fact, despite the fact that 22% of the state's population is African American, 66% of the dialysis population is African American. Ethnic and racial disparities in kidney disease, also looking at the geographic distribution, clearly even more of an urban and rural divide. When you look at almost all east of I-95 here is where the people are dying from kidney disease in the state. So what is it about potentially this Robeson County, which falls in the bottom 25th percentile for kidney disease, which falls in the bottom 1 percentile for health outcomes, about what is it about this area that's potentially unique or potentially worthy of study in terms of health disparities? Well, one of the interesting things about Robeson County are the demographics. It's one of the few counties in the United States that's majority minority. So what I mean by that is over half the population are traditional minority populations. 40% American Indian, 30% African American, 20% white Caucasian, and about 8 to 9% Asian, Hispanic, but also a growing Asian population, believe it or not. And I mentioned American Indian. And the reason that 40% of that population of Robeson County is American Indian is because of the Lumbee Indians. The Lumbee tribe is the largest tribe in North Carolina with 55,000 members, the 9th largest in the United States actually, and it's one of 8 state-recognized tribes, and its home, the home headquarters, the tribal home, the traditional home of the Lumbee Indians is Pembroke, which is in Robeson County. So that's the context of where they live and why 40% of the population is American Indian. So geographically, Robeson County, what is it about it? Well, it's a rural county, over 250,000 farmland, rural agricultural farmland acres. It's a swampy area. The Lumbees actually get their name from tree people living in the trees above the swamps. And this also speaks to this idea of environmental disparities and environmental justice. You know, Hurricane Matthew hit Robeson County last year about as hard as any county. It was on CNN And you always wonder, gosh, why is it that the poorest people seem to get hit the hardest? But it's not a coincidence, right? They live in the swampy area for a reason, because they were disenfranchised, and this was an unwanted area. So then you have something devastating like this happen, 20% of the county was displaced. Economically, it's the poorest county in North Carolina. 33% of the people live below the poverty line. It's higher for the minority populations. It falls in the 0.03 percentile for per capita income in the United States. And in 2012, Lumberton was, in fact, the poorest city in the United States. So if I haven't painted a grim enough picture, let me tell you now about just how bad the health is. So almost no one has health insurance, right? I mean, 22% of adults have no health insurance coverage. 40% are obese, and 2/3 of adults are overweight. And compared with minorities in North Carolina, which we just saw already experience disproportionately worse outcomes for diabetes, hypertension, those in Robeson County have an even twofold greater risk above that for death from hypertension or diabetes. Likewise, kidney disease, compared with minorities in North Carolina, who we know experience disproportionately worse outcomes from kidney disease, those in Robeson County have another twofold greater risk for kidney disease. So with all this in mind, with the CKD Africa study, with my transition from residency and global health training to fellowship to wanting to change my focus to local health disparities, over the last 2 years while at the DCRI, we've started the Kidney NC pilot study, and that's working with local partners in Robeson County to begin to address some of these issues as they pertain initially to kidney disease. And the objectives have been, first of all, just to establish partnerships and engage the community. We can't build a research platform without understanding the needs and engaging the key stakeholders. So that was one of the main objectives of this. We wanted to identify the facilitators and barriers of optimal CKD self-care. And what I mean by that is really, what is it like living with a chronic disease, and what's it like living with kidney disease in this area? How do you achieve or not achieve the things you need to achieve on a daily basis? So what kind of things do you draw on? What resources, psychologically and tangibly, do you use? And then extending that a little bit further, explore the contextual determinants, right? What are the cultural, environmental, family, what are all the contexts in which people are living that help us understand what could be mechanistically causing disparities, and also how we can inform future interventions to address them. So with this in mind, I do want to share with you some of the preliminary results, but thinking about the conceptual framework that we took to understand kidney disease in this area. Kidney disease, as I showed you, is heterogeneous. It can be caused from purely environmental factors to purely genetic factors, and everything in between, right? And truly, it's everything in between and all together. And so this is kind of the approach that we wanted to take to start peeling back the layers of this onion, kind of step by step, to understand where areas that are modifiable and what areas are not modifiable, and what's the attributable risk of each of these factors. So over the last year or so, we've been working on this study, and really the response has been tremendous. Only over a cumulative period of about 8 weeks of enrollment and recruitment, over 350 people have already come in, 2-hour surveys, a lot of stuff, coping, resilience, health literacy, all this stuff, trying to understand, again, their contextual determines their lifestyle. Wanted to do a qualitative portion to really get in depth and understand really what are the nuanced things that are happening and that people would be amenable to. Importantly, biobanking the blood and urine while testing for kidney disease at the same time, because we want to be able to follow this established cohort for a period of time. And I think that these results that I'm going to show you have given us several opportunities to peel back several parts of the onion and start thinking about genetic, behavioral, and environmental determinants. So, genetic. What about family CKD clustering? Well, it turns out that actually the Lumbies, we've seen a lot of clustering of kidney disease, and this could be due to a lot of different reasons, for sure, lifestyle included. But to what extent is there an attributable risk to heritable patterns of kidney disease? We see here that 33% have a family history of kidney disease. That's much higher than even high-risk minorities across the United States. 26% of those with kidney disease have another family member on dialysis. I mean, that's a pretty stunning amount. And people have told us this, right? We saw this in the beginning. This lady talks about all the kidney disease that has been ravaging her family. And so I think that there's a real neat opportunity here, because genetic determinants for kidney disease are are becoming more and more characterized. In the Western American Indians, they've been studied pretty well in Strong Heart and the Zuni Indian projects. However, Eastern American Indians are very different, very different. A lot more admixture with European and African populations, and no one has studied kidney disease genetics in Eastern populations at all with respect to American Indians. Lumbee Indians in particular have high admixture with African Americans. So it really begs the question for some of these potential genetic components or attributable genetic components to the kidney disease stuff. So what we want to do is, and what we've proposed to do is is a heritability study or heritability analysis where we have partnered with the Center for Precision Medicine here at Duke to implement a MeTree program, which they use to collect high quality family health data, which is really amenable to these type of genetic epi studies where you can estimate not just population risk, but familial risk and hereditary risk. And then at the end of the day, you get a number, and you can kind of put something on 20% heritable, 30% heritable. And that's important preliminary data because that allows us to then apply for bigger stuff to do more in-depth genomic studies. So what about the behavioral? There's a lot of opportunities here for behavioral studies, and something you might be interested in is, and not surprising, the self-care behaviors are terrible, and this just kind of confirms that. Low health literacy, very low awareness of kidney disease, real inability to control diet, lifestyle, physical activity, low medication adherence. This kind of tells us what we expected to find. But what's really interesting here and neat is the idea of the family influence on self-care behaviors. The Lumbees really have very strong family ties and family links. There's a lot of shared decision making. People do grocery shopping together. They cook together. They do all these social activities from healing and tribal activities to farming, all these kind of going together. So I think there's an opportunity here to leverage the family unit for a potential place for an intervention or informing an intervention to improve, not just CKD, but all the thing that's it's in the same wheelhouse as diabetes, hypertension and obesity. And what we want to do to explore some of these issues is take advantage of this method that's been employed a few times, but not much. So I won't call it a novel method, but it's certainly not novel to American Indians, but this idea of talking circles. And talking circles are a traditional form of communicating for American Indian tribes. Sitting around, you usually have a talus or something to symbolize who's speaking, and it's a form of communication and storytelling. And you kind of tell your story and what it is. And the reason it's really different from a focus group is that it's not necessarily moderator directed. In fact, the investigators are part of the focus group, or part of the talking circle. So you have to tell your story as part of it as well. So it's a real organic thing that kind of happens and goes through these storytellings. And the other key part here is that the participants have strong social and relational networks. They know each other. In a focus group, they probably don't. You probably don't want them to know each other. Different in a talking circle. This would be really important for a family study where you could get a family together and go through some of these issues. And what we want to understand is the structure and the characteristics and the practices of these families so that we can understand how it's organized, how decisions are made, what are their worldviews, their emotional management, all these different things that would be important for developing some type of lifestyle intervention, lifestyle behavioral intervention. And finally, I'll just show you some of the prelim data and some of the stuff that we're proposing for the environmental component of this and to understand environmental mechanisms. Now, I told you earlier that there were urban risk factors in Moshi that we didn't understand at all, and they were poorly characterized. Well, likewise, the rural risk factors for kidney disease and kidney disease disparities in the United States are very poorly understood. In Robeson County, for example, I mentioned 250,000 farmland acres. Soy, tobacco, animal agriculture. Tobacco requires more pesticides than any other crop grown in the United States. 30% of the population is served by well water in Robeson County. 28% of the homes were built before the year 1970, 10% before the year 1950. And 4 tributaries are on the EPA 303D's water list, at least until they remove it, I guess. And we see this. Again, people tell us this, right? The patients themselves. I'm worried about what's in this. This is one example. They talk about all these other things. And eventually, when enough people tell you that, you kind of, a light bulb goes off and you say, yeah, maybe it's not, maybe there is something to it, right? So we mapped kidney disease prevalence across the county, and this is in partnership with SRMC using their electronic health record data. So it's not pure epi, but we had pretty good county coverage, and this is about 55,000 people that we were able to map across the county. And when you overlay it with where the Lumbees live in the hatched area, you see how the prevalence kind of coincides a little bit. And it turns out that there are areas of geospatial clustering or increased autocorrelation in the county above what's expected for the background prevalence. And when you correlate that with well water consumption, it turns out that there are areas of well water consumption that correlate where those prevalence numbers are high. And looking at it in a different way, this is the same area but a very different map. This is actually showing the correlation between the clusters and elevation. The Lumber River Basin, as it turns out, the entire southern part of the state filters by two rivers into two main watersheds, which are at the lowest elevation points in the county, and they sit here. And this is actually, turns out, where those same clusters are. So if you think about 30% of the county using well water, the potential, and that there are other areas where well water has been very well associated with kidney disease, I think this kind of makes for a compelling hypothesis around just testing it and going out and finding out whether there's an association between the well water and the water consumption practices and kidney disease. When you look at Sri Lanka, this has been done with the CKD unknown. Even in Flint, Michigan, this is stunning. This paper was in 2007, by the way, well before the news came out about it, that there was 25% excess mortality from CKD and stroke and CV death, too, was in that paper, related to groundwater quality. And in West Virginia, this was done around a DuPont factory where they found perfluorinated chemicals from plasticizers and flame retardants. They found an excess risk for kidney disease. It also turns out that there's a big DuPont factory that sits about right there in the southern part of Fayetteville. And finally, putting all that together, I think that provides a lot of opportunities for these translational studies, these environmental studies, but we also want to get into the homes. We have to get into the homes and do kind of full family household assessments to understand how people are living and what's happening. These are actually these are real examples of where we were last summer in some homes doing some other things. And we need to get in and measure water and collect dust and look at the pipes and take pictures and measure well water depth and talk to people and understand how they're cooking and what they're doing so that we can really begin to understand how to intervene and begin to address health disparities in kidney disease. And again, I'll just remind you, this is what many of these homes look like in October, so it even takes on more urgency because people have been even further displaced. So, to close, I think we've pretty much summed up pretty well that Lumbee Indians in Robeson County, that we know, as I've shown you, they live in poverty. They have high CKD burdens, low health care uptake, low education, high underemployment, lifestyle and behavioral risk factors, environmental exposures, and poor health outcomes. And you can say the exact same thing, right, about the people in northern Tanzania. And you can say the exact same thing about many populations across the globe. So I think that highlights to me the importance of understanding this model, not just from the sociological model of the national level, but within a global level. And I think that by studying populations in both directions, right, we want to take what we're learning here and then go back to Tanzania and further our investigations there. And I think that we can answer big questions about CKD epidemiology. This obesity question, I think, could be answered in a sense. We don't know if obesity plays a direct link in kidney disease, for example. But maybe by studying populations with different exposures, different lifestyles, but same obesity, you can answer some of these things from an epi standpoint. The urbanization question is really interesting to me, and this urban-rural transition and what's happening and how it looks different in the U.S. than other countries. So with that, I'll say thank you. A lot of thank yous. This is some of the Kidney NC team, and this is some of the CKD Africa team. I have to show trekking up the road in the rain. A lot of thank yous, obviously, to the DCRI, the leadership, Matt Rowe, Eric Peterson. Ebony Bullware has been a tremendous mentor for me, and Miles Wolf over the last year in formulating the next steps of this and trying to take it to the next level. So thank you very much. Hello, Anne Marie.
Hi, John. So that was great. I think really exciting to see what you're doing, and there's a lot of people get really excited about global health and fabulous international destinations to go, and I just sort of want to give you kudos for realizing there's disparities literally in our backyard and tackling them. I also want to highlight, I've worked with some undergrads that you are actually mentoring who are working for the illustrious Dr. Stanifer. I'd like to, it sounds like you've really developed a coalition of the willing to do this. I would just like to hear a little bit more about who do you have involved in this, and what kind of manpower and coalition you've leveraged to be able to accomplish all of this in a short time?
Yeah. Well, I spend a lot of time in Lumberton, and I've done a lot of the data collection myself. So yeah, how do I do this with essentially almost no money? That's what you're asking, right? So I had a little bit, and the DCRI has been very supportive, and the Executive Directors Fund, which has been a little bit. But you're right, the people power is the toughest. Building the local relationships has been critical. Cherry Beasley is a local investigator at UNC Pembroke that has been phenomenal and facilitates a lot of connections across the county. And our home base is kind of UNC Pembroke, the nursing school there. We have offices there, and people come in and we do our testing there. We've partnered with SRMC and have leased office space there. And then, yeah, training a lot of students. The Global Health Master students have to do a field experience during the summer. And it doesn't have to be abroad, by the way. They can do it here, and they have been. And that's a nice. They're pretty well trained, and they're going through a lot of the quantitative skills, so they do a really good job. And then, yeah, Duke undergrads have been involved in training them. And the trade-off for that is that they're free labor, and they come with some money. But the trade-off is that, well, you have to train them, and it takes a lot of upfront stuff in developing their curriculum to make sure they're doing it appropriately. But it can be done. And they actually have done a phenomenal job the last 2 years. And so we just recruit during the summertime when the students go down and I'm down there and we do this. And that's why I say over a period of about 8 weeks, we're already up, it's over 350 now with 6 weeks last summer and 2 weeks this summer so far. Yeah. But I think the response also from the community probably speaks to how concerning it is to them. When you say kidney disease, they kind of, they know somebody on dialysis. They know about kidney disease enough to be concerned. Hey, Ben.
Curious, has there been any, because of the institutional challenges that this population, was there any resistance to someone from Duke coming in, or was there a barrier that you had to cross to buy into the work that you were doing, or from the beginning was there kind of excitement to help find out about health?
Yeah, I learned a lot about this from my time in Tanzania. I mean, no matter how much I'm down there, no matter how much I know the community, I'll always be a cultural outsider, period. And, there's not a language barrier in Robeson County all the time like there is in Tanzania. But this just gets back to this idea of, one, engaging the community and local partners. It just cannot be done without local partners on the inside that you trust, that they trust you, and that can help facilitate it. But we engage stakeholders at every level and involve them in trying to help formulate the research and the research question. I mean, it would be presumptuous of me to think, I know how to treat these individuals, but taking a step back, it's still presumptuous to even think that I know what the problem is. They know what the problem is, they live it every day. And so that's kind of the approach I take.
Give one more round of applause for our fantastic